So welcome everyone. We're going to present about the toolkit and the research behind it, and we'll stop at several points to answer any questions you have. So do type in your questions in that Q&A box in the bottom right-hand corner of your screen, and we'll keep our eyes open for it. Here's the three of us that are going to present today. And we'll each introduce ourselves as we come to our section, but I'll turn it over to you now, Rose, to begin. Look, yeah, there you are. Off mute. Yeah.
Great, thanks, Nancy. So just a few acknowledgements before we get started. Thanks to the rest of the project team, my colleagues at Centre of Excellence for Women's Health, as well as our collaborative partners, Canadian Centre on Substance Use and Addiction, the Canadian FASD Research Network, and the Prairie Child Welfare Consortium, as well as the wonderful panel of reviewers and advisors we had on this project that really shaped the way that this toolkit has ended up. So much is changing in the substance use and child welfare fields to bring forth approaches that are culturally safe, trauma-informed, harm reduction-oriented, and participant-driven. And the goal of this project was to highlight these approaches with the aim of reducing stigma and improving policy and practice responses for women who use opioids during pregnancy and while parenting. So in generalist systems in the past, substance use and child welfare have taken punitive approaches towards substance-using pregnant women and mothers. We've tended to view the needs of mothers and children as conflicting as opposed to connected, which has led to separating children and mothers when there is parental substance use. And we haven't worked together very well as fields to support the well-being of both parents and children, which has led to stigmatization and re-traumatization. So we engaged in this project, as I said, to highlight these newer approaches that are emerging. And we started the research with three guiding questions. In what ways do women who are pregnant or mothers and use opioids experience stigma? How does this stigma, as well as other factors such as policies, impact women's access to, retention, and outcomes from harm reduction programs, as well as their interactions with child welfare? And what programs, policies, and services could improve outcomes for pregnant women and mothers who use opioids? So we began the project by gathering evidence through a scoping review of literature that was published between 1999 and 2019, as well as reviewing best practice guidelines. And that was organized to answer those three research questions. We then took a summary and a synthesis of these review findings to our working group, and we met both online and face-to-face in a one-day meeting to discuss these findings. The working group consisted of those folks that I acknowledged a few slides back, and they were a group of service providers, academics, policymakers, as well as women with lived experience in both the substance use and child welfare fields. And through their feedback and an iterative process, we translated this information into a guide, including useful and practical tools to help support practice improvements and policy developments. So the resulting toolkit that we're talking about today, Mothering and Opioids, Addressing Stigma and Acting Collaboratively, invites people in both systems to consider how we can continue to improve our work. The toolkit identifies strategies for reducing stigma and improving the health, safety, and social needs of women and their children. It includes 15 action-oriented tools, self-reflection guides, fact sheets, and discussion starters, and it encompasses work at 4 different levels: reducing stigma at the practice level, offering programs and services, cross-system collaboration and joint action, as well as improving policy through a focus on policy values. So we believe that understanding women's experiences when navigating child welfare and substance use services is critical to improve practice and integrating promising approaches. So throughout the research process, we used different ways to include the experiences of women with lived and living experience. Members of our working group, as I mentioned, had lived experience with substance use during pregnancy and parenting. As well, the Her Way Home Advisory Group helped us with reviewing draft sections of the toolkit, as well as developing a tool called 10 Things Pregnant and Parenting Women Who Use Substances Would Like Practitioners to Know. And Her Way Home is located in Victoria, BC, and they provide non-judgmental health and social supports for pregnant and parenting women who use substances, as well as face other health and social concerns. And their Women's Advisory Group is an established group that provides input on their services and programming. As well as when we were conducting the scoping review, in the first research question, in what ways do women who are pregnant or mothers who use opioids experience stigma, we focused on literature that had been published already that was on women's experiences from their own perspectives. So we only included papers that were research such as interviews and focus groups. And we've incorporated some of the quotations from that research into the toolkit as well. This photo here is a screenshot from the toolkit, and we also have examples in the toolkit of digital narratives and videos by women who use substances. And these videos can help people who work in the system of care better understand how practice and policy can support women and who use opioids and their families. So we're going to walk through the toolkit section by section a little bit and show you what's inside, as well as summarize some of the literature that supported the tools that we developed. So the first section of the toolkit focuses on identifying and reducing stigmatizing practices. Pregnant women who use opioids are often judged and stigmatized for using substances and are often discriminated against when seeking care. Judgment from service providers is consistently listed as a barrier, a significant barrier to accessing services. However, service providers can be unaware of how their own behaviors and attitudes can contribute to the stigmatization. My goodness. The stigma associated with substance use during pregnancy has led some practitioners to take punitive approaches to working with women. Historically in Canada, Indigenous and racialized women have been particularly stigmatized by the reproductive health and child welfare fields, which has resulted in mother, child, and family, as well as community separation, increased surveillance, and requirements for stricter levels of compliance. So the tools in this section include self-assessments for identifying potentially stigmatizing behaviors, attitudes, and languages, a script for how to respond when you see a coworker acting in stigmatizing ways, and a list of suggestions, as I mentioned, that was developed by women with lived experience. So for each section of the toolkit, we're going to show you an example of the paper that was included in that section of the scoping review. So as I said, to answer the first research question, we included qualitative research that explored women's experiences of using drugs during pregnancy. We located 16 papers in total. 8 of these specifically focused on opioids, and all were about women who were undergoing medically assisted treatment for opioid use disorders, except for 2 that also included women who use prescription pain medication. Across these studies, they identified that stigma was a pervasive force in women's lives, and it reinforced social blame and isolation. Women also internalized these negative attitudes, which led to self-consciousness, guilt, and blame. And these feelings affected women's confidence in their ability to parent, as well as from attempting to seek treatment services at all. So the paper that's up here was a study by Heather Howard, published in 2015, and she interviewed 20 postpartum women who used prescription medications, including methadone and buprenorphine, as well as synthetic narcotic analgesics like oxycodone. However, she did exclude women who used heroin as their primary drug choice. And she organized her findings of these interviews into 2 main themes. The internal stigma that represented feelings of shame, guilt, and fear, as well as the external stigma that represented the enacted stigma or discrimination towards pregnant opioid-dependent women. And in her conclusion, she said that service providers need to be aware of how their behaviors could increase or decrease stigmatizing responses. So we incorporated findings such as this into our toolkit and created tools such as the next one I'm going to show you. So this is an example of one of the tools from that first section. And it is a practitioner self-assessment. So it includes 15 statements like, I believe that women who use opioids can be good mothers, or I think that women using medication for treating opioid use disorder should try and cut down their dosage during pregnancy. It asks people to reflect on their attitudes, knowledge, and behavior, and then rate on a scale from 1 to 10 how much they agree or disagree with the statement. After the service provider reflected on all of the statements, they are asked to consider a few additional reflection questions. How did it feel to think about these statements? Are there any statements that got you stuck or you had a hard time with? And how might your attitudes, awareness, assumptions, or approach impact the way that you work with women who use opioids? So here's an example of another tool. The section of the toolkit also includes a script that was developed to address peer attitudes and stigma related to substance use during pregnancy. It was adapted from an Acknowledge, Create, Circumstances for Reflection, Teach and Support tool, or ACTS, that was published by Lenora Marsalis, one of the members of our working group, as well as her colleague, Betty Pogue. And it can be used to help service providers know what to say and how to respond respectively and constructively when they see a coworker acting in stigmatizing or judgmental ways. And it provides examples on how to redirect conversations to encourage exploration of underlying assumptions, positive possibilities, as well as build capacity and incorporating a more compassionate view of women. I'm going to turn it over now to my colleague, Lindsay, and she's going to talk to you about the second section of the toolkit.
Thanks, Rose. Hi, everyone. My name is Lindsay Wolfson. I'm the research coordinator at the Center of Excellence for Women's Health, and today I will be talking about the second section, as Rose mentioned. So the second section really focused on improving programs and services. This section includes a number of tools to highlight approaches that emphasize mother-child togetherness, the importance of involving mothers in collaboration, and that are holistic, harm reduction-oriented, trauma and violence-informed, and concerned with Indigenous wellness and safety. These approaches recognize that a continuum of responses for mothers with substance use concerns is needed, as no one approach will work for everyone, and that each woman may need or be ready to access different services at different points in time. This section also highlights promising approaches that can be used in both sectors, such as one-stop shops, care coordination, and mentoring, and has tools that allow for critical reflection on existing services and programs. For this second section, and to address the second research question, 58 papers were included. Stigma was mentioned in 25 of the included papers. It really was the most commonly cited barrier for women engaging with the child welfare services, but it also influenced how much women engage with harm reduction and substance use treatment services. Barriers to engaging with child welfare in the literature included distrust of the child welfare system, punitive approaches, fear of apprehension or prosecution, fear of contributing to their children's trauma. And there are also barriers to reunification, such as poverty, being a recipient of social assistance, a lack of housing, unemployment, and family size. Literature describes the extra obstacles and unrealistic treatment plans to women that were required to meet in order to demonstrate maternal capacity and be able to be reunified with their children. However, there were similar barriers identified within the substance use field. Fear of child welfare and child apprehension was the #1 barrier for access cited in the substance use literature. However, a lack of family-centered programming was the biggest barrier to substance use treatment retention and the impact on the child welfare system, such as increasing substance use after apprehension, was the most common barrier to successful outcomes. Most of the literature we reviewed was American, though, and so in that literature, we were seeing how medically assisted treatment was also largely unavailable for pregnant women, despite it being a best practice for women with an opioid use disorder. These differing priorities between child welfare and harm reduction and substance use treatment, as well as interagency obstacles such as poor communication and coordination across services and competing goals, were also included as barriers. In this particular study on the slide from Cook and Banga, the article presents the voices of 10 women from 3 sites in Vancouver regarding their recovery needs and the incentives and disincentives to engagement in the recovery program. What they found was the need for collaborative relationships with child protection workers was identified as central to women's recovery. 6 of the 10 women identified the need for child protection services intervention during pregnancy and indicated that they would have readily engaged with CPS if they felt supported rather than threatened. They realized the benefits of early intervention in their recovery process, and they really found that it would have had better health outcomes for themselves and their children. A second theme was the inclusion of children as part of women's recovery process and the recognition of the importance of women's attachment to their children. 9 of the women indicated that they gained strength from their children, and those children became their motivation for change. Conversely, when children were removed from their care, it was associated with relapse and long-term addiction. Women who were able to attend recovery programs with their children indicated that they received the help they needed and maintained recovery because of a sense of responsibility to theirs and their children's needs. Having children in the recovery process, allowing them to actively parent, was both powerful in the recovery process, but one of the most cited barriers across the research. Finally, several women said that recovery programs should also consider the multiple needs of substance use, pregnant, and mothering women in the context of their lives, rather than only providing addiction recovery. That would include services that recognize housing, transportation, and emphasis and social supports under one roof, rather than only focusing on addiction services. And women really wanted the support of social workers to help gain access to recovery programs where those other social determinants of health were incorporated, and where women had the opportunity to talk about underlying issues relating to their substance use. Overall, what this study found is that women are prevented from engaging in recovery programs and services due to ongoing child protection policies, but that non-judgmental, strengths-based, and collaborative relationships with child welfare can facilitate engagement in recovery. What I'll be focusing on here is the bottom of the slide where we're really talking about shared approaches. These shared approaches that are listed towards the bottom demonstrate a range of evidence-based and values-based approaches that were evident in the research that we reviewed. And those are really important to working with pregnant and parenting women in the child welfare and substance use fields. In this second section, one of the tools describes these approaches and offers an opportunity to reflect on how your agency currently incorporates these approaches and how they may be further integrated into your work. For example, the first shared approach, mother-child connectedness or togetherness, values keeping families together. While this may be in relation to child custody, it can also include rooming in models of maternity care, whereby the mother-infant diet is kept together postpartum to support close, uninterrupted contact between women and their infants, to decrease the impact of neonatal opioid withdrawal, lessen the need for pharmacological interventions, and shorten hospital stays, but can also include integrated addictions treatment or community and peer support outreach. Another example of a shared approach would be the integration of harm reduction, which does not require abstinence from substances and provides a continuum of care that includes abstinence-oriented treatment and holistic wellness support to meet a variety of recovery needs. When reflecting on these approaches, the tool asks, how are agencies bringing in these approaches, and in what ways can we further incorporate these approaches into our agency? As I mentioned, in the literature, we found that there are significant barriers that prevent women from accessing substance use services or engaging in child welfare. This tool, reflecting on barriers and what we can do to reduce them, describes 7 key barriers identified in both fields and offers examples of how programs can address these barriers and reflect on what services or approaches can be integrated into your work in response to these barriers. While stigma, mistrust, and fear of child apprehension may be the most common barriers that we saw in the literature, the other key barriers were quite significant. As I mentioned, in reviewing the Crook and Bang article, for example, the lack of women and family-centered programs really prevents women from staying in treatment due to fear of child apprehension or lack of available childcare, makes programs less able to respond to gender-specific issues or concerns, and by integrating women and family-centered programs or child minding into substance use, programs are able to better address those concerns. One of the other findings, as I mentioned, was that programs really do have these high and competing expectations that increase women's stress to perform as a good mother, encourage her to meet an unrealistic set of tasks that address many determinants of health, such as treatment, completion, safe housing, employment, social networks, and require her to navigate complex systems of care. In the second column of this tool, where we're identifying how programs can be integrating or addressing these barriers within their programs, we're able to see that improved communication and cross-system collaboration can address the high and competing expectations and better support women as they're navigating through child welfare and harm reduction programs. Another component of this section was fact sheets. And one of the fact sheets that we wanted to include was a focus on Indigenous approaches to child welfare and substance use. The relationship between substance use, child welfare, and Indigenous peoples is deeply complex. For Indigenous women, discrimination, racism, structural and colonial violence, and intergenerational trauma contribute and continue to be additional barriers to discussing substance use or seeking support for problematic substance use. However, in the last few years, there's really been a shift to Indigenous approaches to wellness and healing that recognize the influence of these historical and intergenerational concerns such as trauma, colonial policies and practices, and institutional and systemic racism and child welfare involvement in parental substance use. The 6 principles that we have highlighted in this particular fact sheet were co-created by Indigenous health and wellness and substance use researchers. These approaches highlight the importance of supporting women and their families, of adopting strengths-based approaches that champion Indigenous women and their families' wellness, and avoid deficit-based and stigmatizing language and behaviors that encourage service provision that wraps around the mother-child dyad and address the social and structural determinants of health, moving care away from one that recognizes individual blame or stigma and reframes the conversation to be around substance use and better support for mothers, families, and their communities. In the fact sheet, we describe what each of the approaches does look like, but for more information on how these approaches can be used in community-based or driven settings, we also recently released a booklet entitled Revitalizing Culture and Healing, which can be found on our website and which I'll be linking below in the chat box for all the participants.
So, the third section is all about collaborative practices in child welfare and substance use, and is inclusive as well of the many other connected fields like housing, healthcare, anti-violence services, etc. And, you know, the interesting thing, we found a lot of evidence in the literature about collaborative models being able to directly lead to higher referrals to and receipt of substance use services amongst child welfare clients, greater attainment of women's substance use treatment goals, and increased retention of custody and greater reunification if custody has been previously lost. So, you know, a real strong message, as you've heard from Rose and Lindsay as well, coming through this is that a lot of this work can be greatly improved through this concept of collaboration. So the tools in this section are really provided to facilitate and offer approaches to cross-system collaboration. So we found a total of 98 papers in this section that describe promising program services or policies that represented this kind of collaboration. And I just picked one of them here from Australia, and it was based on the New South Wales government allocating funding to establish 4 Keep Them Safe whole family teams as pilot programs. And these teams address child protection concerns in the context of parental mental health and/or substance use problems. And for about 6 months, the staff worked with families who were referred through community and child welfare services to provide assessments and treatment for the whole family. And including things like parenting skills training, substance use interventions, child resilience support, etc. And then following this kind of initial kind of finding out what people wanted, each family was allocated a key worker to oversee the needs of the family as a whole. And each individual in the family is also allocated a specific worker based on each client's needs and the clinician's expertise. And, you know, while it was based on a 6-month intervention, the duration of the treatment really varied. And, you know, and that wasn't a strict, you know, okay, bye, it's your 6 months is over thing. But I think it was really a great example of how effective it can be when you collaborate and keep families together and engage the whole family in recovery. So here's one of the tools that was in this section, and I know it seems obvious, but really one of the things that we saw as collaborative evidence-based approach was people actually spending some time identifying community services that are available. And this tool is really about that. And, you know, it really gets us thinking about additional types of services and providers that can support mothers, children, and mother-child togetherness. And so really gives us a chance to kind of brainstorm this idea that we need to build a net of support with women because, and the services that are in a position to support women and children because of this idea, like Charlotte Caswell once said, there's many roads, one journey in recovery, and that services addressing a lot of different determinants of health can work together. They can be co-located as they are in some programs like She Way and Her Way and others that are working in those one-stop models, or they can work as a network of services, all kind of ascribing together to these common values of being mother-child centered, trauma-informed, harm-reducing, culturally safe, and just thinking through how can we link up our work in ways that really support the varied needs of different families. So here's another tool in this section that seems kind of obvious in some ways because it really is a kind of basic tips for cross-system collaboration. And so it builds on this research about collaboration between the two fields, building and enhancing relationships, learning and training together. And in some cases, deciding to co-locate to better offer connections so women aren't forced to tell their story many times or travel in many different locations, and to find a welcoming, collaborative relationship between their various workers. So, I think these kinds of cohesive working relationships between the sectors can really foster advocacy, consultation, system navigation, safety planning, and streamlined referrals. And so, there's lots of ways in which we can think about cross-system collaboration, and it doesn't need to be one-directional. It can really be many connections, so that we empower women and families to co-identify their treatment goals with us. So the last section really reminds us that this is not only the work of women and not only the work of service providers, but is also the work of people working within governments and other organizations that are thinking about the kinds of policies that need to be in place for these kinds of collaborations and services and supports for women and families to exist. And so really, our big story in this section is that, we really need to make some significant strides in policy as well as practice if we're going to improve the response to mothers who use opioids. And so this section just includes one tool that really gets us thinking about policy values and how important it is for those to be in place. And, the child welfare and substance use fields have traditionally had really different responsibilities and really worked from different paradigms. And for example, if we think about the substance use field, has always, or hopefully always, thought of recovery as a non-linear process, and where relapse will happen and be common and part of the journey. However, sometimes in that child welfare field, relapse was really viewed as an indication that mothers weren't changing and that children required protection. So, we felt here that building on some work we did quite a few years ago now in a study called Mothering Under Duress, is to really think about what kinds of values underpin our policies, and really think about how policies for collaborative practice require, attention to these kinds of policy values. So really get us thinking about this as, what lies underneath the services and policies we have. And this last tool really invites people to discuss values one by one at a staff meeting or during strategic planning sessions or whatever, to think about how we could aspire to these values. And, just some questions that are included here, because it's kind of small on the screen to see, around inclusive engagement. For instance, does the input include women from a whole range of cultural, age, race, class, and regional backgrounds? So that it's not only one person added to an advisory group, but really thoughtfully thinking about engagement. Under structurally supportive, are you collaborating with other systems and services to actively link services in mental health, violence, housing, and income supports to help women and their children progress? And under the idea of embracing complexity, one of the questions that your staff group might think about is, does the policy use an expanded risk assessment model that doesn't just focus on risk associated with substances, but all the risks and harms that women are and families are facing? And finally, you know, my favorite one is always this idea about being respectful and optimistic in our work. And just one of the example questions there is there an underlying compassion for women and an understanding that women want the best for their children and can change? So it's a, you know, it's a great tool for really getting us thinking a lot about these core policy values. And, you know, that idea of respect, I think, is really one that underlies the whole toolkit. We tried to really pull in research and practice wisdom and the women with lived and living experience to really advance our work in the support of mothers who use opioids. And we really wanted to stress that we really respect the work being done by people who are working in the substance use and child welfare fields, and saw in the literature and in the practice wisdom that really a lot of advances are being made. And so this tool is really meant to support and advance this work so that mothers with substance use problems can find the help that they need and so richly deserve. So we, of course, want to leave the story in the hands of the women who gave us ideas about what they thought was important. And Rose mentioned at the first that one of the tools is in this is 10 things that pregnant and parenting women who use substances would like practitioners to know. And I'm just going to read you a couple of them. The first one is mothers want to succeed, so don't assume we're not trying or that we've chosen the challenges we are facing. It's important for you to listen and be curious about what might work for each of us, and to be educated, because there's a lot of things that play into addiction. And, you know, a really strong one that they mentioned was just because you're still using does not make you a bad mother. And finally, you know, that 10th one there is don't judge, instead care. So lots of great advice from those women. In keeping with this idea of optimism and the voices of women and the understanding and listening to their situations, in the toolkit there are also some scenarios with women in different locations and really facing a range of different challenges. And all of these scenarios come from an optimistic place of showing that they ended up well for various reasons and supports. And I just think it's important for us to recognize and to be able to wrestle with some of the questions that that these narratives provide us, that really get us thinking about how might we have reacted to women had they come into our office or workspace in whatever location we're at, and what are some of the things that are opportunities for us to offer, given some of the things that have been covered in the toolkit.
Thanks, Nancy. I realized I didn't introduce myself when I first started talking. My name is Rose Schmidt, and I'm the research manager at the Center of Excellence for Women's Health. And I'm seeing a lot of questions about whether or not you received the toolkit and the webinar slides, et cetera. So I'm going to take you through some next steps, which will hopefully answer those questions. And then we'll pause for a minute and go through and see if there's any sort of content questions before we finish up today. So along our timeline, here we are today on November 28th, listening to this webinar. In the next week or so, I will send everyone who has registered for the webinar a recording of what I'm saying right now, as well as a link to the online version of the toolkit. The toolkit will also be posted on our website, which is bccewh.bc.ca, as well as a link to this webinar will be under our webinar and trainings section. In that email, I'm also going to invite you to participate in the evaluation of this toolkit. So if you agree to participate or you'd like to receive a copy of this, we will send out paper copies in addition to the electronic copies. And in December, that will happen in December. And then 1 month later, in early January, I'll send a link to the online evaluation survey. So it'll be a pretty quick online survey that'll ask you questions like, did you see the toolkit? Did you remember the toolkit? Did you read the toolkit? Did you like it? Did you use it? As well as a few questions about stigmatizing attitudes, behaviors, and practices. And then you can do what you wish with the toolkit if it's useful, or if you want to use it as a discussion guide or in your staff meetings, however it is useful to you. And then 6 months later, everyone who participated in the first evaluation survey will be sent a link to the second evaluation survey in June, which will ask the same questions, as well as a few additional ones, like have you changed any of your practices? Have any of your policies been shifted? So that's the next step. So you will receive a copy of the toolkit, a PDF of the toolkit, a link to the recording of this webinar, and an invitation to participate in that evaluation process.
Thanks, Rose. So there are a couple of content questions that I think we could answer. One of them is a little bit is one about alcohol. And, you know, I really agree with the person who's raised this question. And, you know, we have really been keen to link up the work on cannabis, alcohol, opioids, and tobacco in the work at the center, really recognizing that they're, you know, often really linked and really important for us to think about talking about them together and trying to resist this idea that, you know, we can only do an intervention about one substance at a time. And we definitely see the challenges, particularly in the perinatal period around alcohol, but in general with rising levels of binge drinking amongst women in Canada and increasing hospitalizations amongst girls for alcohol poisoning, etc. So we definitely agree that it's important to link them up together and to use some of the elements of this approach today for all of the substances, about thinking about how can we get behind the goals of women and children and families, and really listen for what kinds of changes they feel able to make, and provide this kind of respectful, trauma-informed, harm-reducing levels of support. So really, really important question, I think, for us to work on this together. Just looking down here for other questions.
There's a question about transition houses, and if we know any resources or best practices for people who may struggle with the capacity to support women who use substances in transition housing.
I know there's lots of transition houses across Canada that are working on these issues, and I know the BC Society of Transition Houses has done a fair bit of work and training on that. I don't know whether you're from BC or not, but there's lots of connection possible. And if you get in touch with us post the webinar, we're happy to link you up with some of the tools that we know that the Transition House movement have put in place. So really, really happy, and really encourage you to go to our website and see if there's anything there that can be really helpful to you. We have produced a few sheets for service providers on the 4 substances I mentioned that talk about the effects of those substances on women's health, on pregnancy, on breastfeeding, and on parenting. So hopefully those might be a bit of help as well.
I can also share a link that we have from another project that we were working on, which was about the role of anti-violence workers and those who are working in interval and transition houses in providing brief support on substance use. It may not address the entirety of the question, but was a pretty comprehensive webinar that we did, I think 2 years back, that I think would answer a component of your question as well.
I don't see any other questions right now, and I want to make sure that before we end, we really acknowledge the funding for this project is coming from Health Canada, and we're very grateful for this funding, and really want to stress that this may not be the official views of Health Canada, but the importance of this kind of support so we can explore these important issues we're really grateful for. So we'll just wait a minute and see if there's any more questions that get
So there's a couple of questions about other sort of intersecting variables such as methamphetamine use or domestic violence, and just how we address that in the toolkit, or if there's any discussion around that as well.
Mm-hmm. Yes, well, speaking of Health Canada, we have applied for some additional funding that we haven't heard from about yet on the issue of methamphetamines, and it is a really important issue and interconnection, and not nearly enough is available in the research world as of yet to really understand that, but there are beginning to be some promising practices, and so we're hoping, and as one of our next projects, we'll be able to dig a bit more deeply into that particular intersection, which falls on the stimulant end of the substance use fields, many types of substances. And, whereas the opioids and the alcohol are really on the other end, the depressant ones. And so I do think we need to think lots about how we really understand the differing needs of those different substances, and at the same time link together some of the elements from this toolkit about best practices as we think about, how do we provide trauma-informed, culturally safe, harm reduction-oriented interventions, and link up with all the other services that are in a position to support families in this. So I think, there's lots of different ways of us thinking through this together, and we hope that we'll be able to spend some more concentrated time on that, just as we've had the privilege of digging a bit deeper into the issue of mothering and opioids. Lindsay, I think, has put up the link to the toolkit that we did that did involve groups like Planned Parenthood and others I see on the list here working in sexual health and many other fields. That's called Doorways to Conversations. And I think it's a really interesting one where we really do try and support people in thinking about what in your wheelhouse connects to substance use issues, and how can you integrate conversations into your practice, that conversations that are about substances. And I think, it's such a great opportunity when people have come for other services, and that to be able to practice these non-stigmatizing approaches by, really respectfully and non-judgmentally weaving into our discussions the, best evidence about the various substances and brief intervention.
So there's a question that I can answer kind of quickly about the outcome measures that we're going to use to evaluate the toolkit. And thanks, Laurie, for that one. We will be using the Standardized Health Canada Knowledge Exchange Outcome Tool. So it includes about 40 questions that start with really basic. Did you see the toolkit, or whatever knowledge exchange product it happens to be measuring? And then it goes all the way through, have you implemented best practices that are recommended in this? And throughout that, we have also left open-ended responses in our survey. So if someone says, yes, I have made a change in my practice, we'll be able to collect the information about what they say that they have, what they've changed. And there's another question here, maybe we can fit in just before we finish up, about interventions that may work especially well in First Nations communities.
So what we included in the toolkit wasn't related to specific interventions, but to 6 practice approaches. And part of why we included those practice approaches rather than specific examples was because interventions that are going to work in First Nations communities are going to be very community specific. However, these practice approaches or principles we found have been in line with many First Nations, Métis, and Inuit values and belief systems. So we've included them there. However, I did also include a link to another resource that we have recently produced, which is on revitalizing culture and healing, and it is more closely related to alcohol or substance use more broadly rather than opioid use, but demonstrates how 7 programs actually use these principles in practice. And so that is available on our website, and I linked it in the chat box and in the Q&A as well. And Nancy, please feel free to add to that point as well.
No, I think you did a great job of answering that. And we have really learned and benefited from collaborations with the First Nations Health Authority in BC, with the Thunderbird Partnership Foundation, and many other individual communities across Canada and some governments, and on these issues. And we really look forward to thinking further on these ideas and their enactment in Indigenous communities. So it's really important question, and we really one that we think needs to be front and center in our reconciliation work.
So one more question here I think we have time for. Aggie asks, when we're looking at cross-system collaboration, did we find ways that we overcome issues related to privacy, consent, confidentiality, and disclosure? I think it's a question we've been asked quite a bit actually in this process.
Mm-hmm. And to me, that's one that is really, when I did some research with Dr. Laurie Drabble from California, where we interviewed child welfare workers and substance use workers about collaboration. That was central. And I think, it was quite individual to different different workers, trying to sort that out together in different contexts. And I think we could use a broader, system level value on trying to figure out that complicated question about how much we can share and what are ways we can share so that we don't come up against the privacy legislation, etc., but also really work for the benefit of women and their families. And, a number of them mentioned to us in that research ways of doing that through various processes of centering the women and bringing their workers together to discuss what they wanted shared and how that might be made more helpful to her rather than seen as a conflict. So, there are programs that we saw in the literature like Signs of Safety that are ways of, talking to women in the child welfare context that really is centered in that way with lots of input from women and families in the process about how their path might unfold and which services they want in what order, etc. And I just think that it's really starting to be seen that it is so much more important to be helpful than it is to be in the box on those issues.
And I think it may also, I just wanted to add on to that, one of the tools in the toolkit in that third section that Nancy had presented on, it's called the Checklist for Joint Safety and Treatment Planning with Families. And it does address a lot of those concerns using the approaches that Nancy had just discussed. It really has to be individualized and collaborative, but it does ensure that it is a consideration when implementing practice approaches.
So maybe we'll just wrap it up with that. And, we just really appreciate the number of people who've expressed interest in this work. And we really hope you will stay connected to us through the process that Rose mentioned in terms of downloading the kit, using it, and we also have lots of copies that we hope that people will actually get in that are print copies, and we're really keen to know how you and what you find from the kit that is useful to you, and really give us feedback on that in the 6-month checkup. And it's really important to us that we create the kinds of things that are really helpful to you as policy research service and women with lived experiences. So we're very keen to keep engaged with you on this work. So thanks for coming today.